Morning, everybody. Welcome. Nice to see so many faces in the audience. And obviously, we've got a number online as well. So I'm just going to run through a quick introduction and then hand over to the speakers. So welcome to Design-Led Innovation in Healthcare. I'm Dawn Musgrave. I'm the Industry Partnership Lead for the Innovation Observatory. So the slides will come out, so I literally just whiz through these. So that's our mission statement and what we do. So we do horizon scanning, future foresights, what's coming into the market in terms of medtech and medicine, and we produce a whole number of reports, data, insights which are available. There's a number of publicly facing ones which are available on the website. If you just go to resources, you can go there and search through. So we work with a number of stakeholders. So we're funded by the NIHR, and then we also work with NHS England, NICE, and we keep the technology assessments. We're part of the committee and panel for that, and the Gateway. And that'll be another talk in February, which I'll put details up from in a minute. And then we also wider work with MHRA, the UK Health and Security Agency, and devolved nations as well, so across the whole of the UK. Our model is an engagement model, so we work with industry partners and stakeholders nationally, and also business support, business development, etc. So that whole ecosystem around business. One of our aims is knowledge mobilisation across industry, and we do that through events such as today. So this is one of a monthly event. So January's event is horizon scanning, what we saw 24, what we're predicting kind of 25 and onwards. So a state of the nation, what's been happening in the sector, and just some key insights there. That's a map of the ecosystem that we work within, which is actually live, so it doesn't look so great static, but just to illustrate the complexity and empathy for any SMEs out there, because it's a very complex ecosystem. And one of the ways that we support, I don't know what's happened there, that wasn't me. One of the ways we support, lost my track there. So one of the ways we support SMEs is to signpost and navigate that system. So obviously we work with partners, stakeholders nationally, and we, if we can't help, because we can't actually do one-to-one with SMEs, but we'll signpost to our national collective of stakeholders and partners to the right person. So that's just a bit about how we actually do horizon scanning. So we have a whole team in the Innovation Observatory that work on data science and AI, and we have a number of scanning tools that are internal and external facing, and that's how we produce our horizon scanning reports. And I won't even go into that in any more detail because that's a whole workshop on its own, which we've done a number of times and will do in the future. So that's just to illustrate OpenScan 2. So that's currently our data scan and AI tool that's been upgraded. So that started in 2024 and moving into 25. So that's how that works. So as mentioned, Talking Point Tuesdays, this is our monthly meetup, specifically for SMEs in the sector. So networking, hybrid event, so physical, or people have the opportunity to dial in because it's national and we work nationally. So typical itinerary, networking, and then we go into keynotes, and then we have an expert panel. So we did NIHR funding, so what is available in terms of NIHR funding, and today, as you know, is Design-Led Innovation. January, as mentioned, State of the Nation, and then February we move into NICE, which is early assessment, making an early assessment to NICE, And then March is health economics. I was trying to work out what the missing word was there, but it's health economics. And then April, digital health, sustainability and health, PPIE and making grant applications, and then looking at internationalisation and global work. So this is the event in January, and there is a QR code which will come up. But just wanted to mention that part of today and every session, we have the opportunity for you to have a 10-minute one-to-one with experts and virtual residents. So today's experts, we've got Ben Porter, who's in the audience over there. We've got Megan Foden, who's dialing in from Alder Hey Innovation. And we've got Lindsay, who's also in the audience. And Matthew, who's also in the audience as experts. And they'll be joined by the Innovation Observatory team as well to support. So how we helped SMEs in industry previously. So as mentioned, the model is one-to-many, it's capacity building. So it's showing people how to do horizon scanning themselves, signposting. So where we can share information, we do that and put people in the right direction. So coming soon, we've got a newsletter coming up, so you can subscribe for the newsletter and the subscriptions on the website. And there's the QR codes. So for the future events, if you want to register for the events that I just showed for next year, then the QR code's on the slides or on the screen for Eventbrite, so you can just go to that and register for future events. So moving on to today, I'm going to hand over to Richard, who is going to give his keynote, and I will move out the way.
Thank you. Good morning, everybody. Good morning to those online as well. Sound okay? Yeah. Good, brilliant. So I've got 15 minutes. This might be quite a quick presentation, but I'm from industry. I run a product design, innovation and sustainability consultancy based in the north of England. We've got clients nationally and internationally. In terms of projects we worked on over the last 20 years, we are primarily health tech related. So on this slide shows that we work with a range of clients from high growth startups to SMEs, manufacturers, PLCs and universities as well. Here's a range of clients that we work with, some in the region. And here's just two very brief projects that we worked on recently. The one on the left is Frugal Innovation, so working with NEHR to look at gasless laparoscopy. So at the moment with keyhole surgery, you have CO2 to insulate the abdomen, and the challenge of that is in low to middle income countries, that's not available. So we worked with the NEHR and University of Leeds to devise a system which was effectively a mechanical lift that goes into the umbilicus, creates tenting that then allows the surgeon to carry out keyhole surgery. So it's safe surgery, but it's a Frugal Innovation adoption. So I've been spending a lot of time in India on this project. It's already out there, and we're looking at deploying it into Africa, sub-Saharan Africa. On the right-hand side is a Design Foundations project. We are heavily involved in sustainability, helping organisations to understand the net zero, the NHS net zero 2045 targets, and how organisations mobilise around that. So how do you actually do it? So this is a project which was funded by Innovate UK, looking at temporary pacing leads and how we can decarbonise them. So currently, temporary pacing leads are incinerated, and that's got a huge cost and carbon burden to NHS. So that is an early stage project. But it's not, the point here is not what we do, it's kind of how we do it. And these are things I want to share with you over this kind of talk. So the best way to describe us as a company, PDM, is thinking and doing. These are aspects in terms of the thinking, which is the strategic aspects, and the doing is we are innovators, product designers, engineers, the actual implementation. So we're kind of unique in terms of that value proposition of, as well as consulting, actually doing. So this is something I want to share with you. I'm actually an assessor for Innovate UK, so I've kind of pinched this from Innovate UK from one of their slide decks. This shows what innovation is actually about, particularly from the design perspective. So you have an A to B, and people normally think that innovating is a nice linear line, nice straight line in terms of you have the idea, you create a concept, you make a prototype, you talk to some people, you get some feedback and you launch the product. But the reality is there's this thing called fog of uncertainty. And for us, it's really important that we interrogate, and I use that word wisely, clients of all sizes and ranges to really understand that uncertainty, because innovation R&D is a very high-risk business that requires a lot of budget and time. So what we do is hold clients in that uncertainty until we've got complete clarity. And part of that, which I'll talk about in a bit, is about interrogating the user, user-centered design, so really understanding the brief. We've seen lots of projects that have kind of gone south because they've not really understood the user properly. So this is really useful. It's a very simple graphic, but very useful. Another one here, this is more kind of summative. This is the Gartner Hype Cycle. This is kind of how particularly startups behave in that innovation journey. So you have the trigger, A, which might be that it's disruptive, it uses a new technology, for example, wearables. It's a different value proposition to the NHS, for example. And then it kind of, the hype cycle goes to the peak of inflated expectations, where everybody thinks they're going to make lots of money and they've got something truly innovative. But sure enough, what will happen is they'll fall into this trough of disillusionment, or valley of death, as it's known, where there's issues with IP, commercial viability, the team, budgets, etc., etc. And if you are successful and you persevere, then you go to the slope of enlightenment and plateau of productivity. So I know lots of organisations that fall into the trough of disillusionment, and we get lots of wry smiles in the audience, which I can just see right now. The point in design terms, I'm going to kind of champion design, is that if you have a design innovation house that understands the whole process of innovation, then they should be the blue line that people like me, that prevent people getting too excited, and I'm kind of the doomsayer about it's not as easy as that, but also they will mitigate that trough of disillusionment and hopefully get you to that plateau of productivity. So this is the core of my talk, which is 10 things that you need to know when approaching design in innovation. This is a broad brush. I could do a very deep dive into this, but I don't have time. The first one is fail fast, fail cheap. So I'm an expert for the Design Council, so I'm kind of championing killing ideas early. The point of this slide is that it's not really about killing a project completely wholesale. It's about understanding where those risks are. So if we can find in an early stage project where it's potentially compromised, which could be any aspect of a project, then we can fix them. The whole point here is to change your mindset in terms of rather than having a conscious bias that you can be really successful, think about it the other way around in terms of a bit more critical thinking. Second one is the right people. So I've got an MSc in leadership, so I'm fascinated by how leadership and innovation are interdependent and how really good ideas fail because they've got bad leadership or bad teams around them. So what might happen in the project is that people don't understand the same language, there's potentially infighting, or there's groupthink where organisations have the kind of same methodology and they kind of all got the same bias, which will eventually not be commercially viable because they've not got somebody that challenges them. The best way to describe this, and I'm not a Star Wars fan, so I've not done it for that reason, is that I like to look at organisations as a complete mix of different people. So in the context of Star Wars, you've on the top right, on the right-hand side there, you've got the muscles that kind of smashes doors down. You've got the guy, I don't even know his name, the guy in the tin suit that knows 700 languages, and is an incredible buff, and he can give you any statistic that you like. Then you've got Han Solo, who's kind of the charmer, kind of gets through doors, that kind of stuff. He kind of warms people up. But the whole point of this slide as well is that you've got a Jedi Knight So I'm a firm believer in mentoring and getting the right people around you. So we've got a non-exec chairman who is our Jedi Knight. So it's really important to, if you can access that resource early on, then it will help you to understand your value proposition and allow you to kind of work together as a team. It sounds really obvious, but there are organisations that don't have that mix of characteristics. And some organisations see, if you have a maverick, that see it as a bad thing, but I actually see it as a good thing. Be receptive to change. So we do work with academics. So we have worked with Durham, we work with York, Leeds, Loughborough, and I'm not picking on academics particularly, but sometimes there are personalities of people that don't understand what the innovation journey actually is, and they are not receptive to change. The reality is that if you are the instigator, the originator of a piece of academic work that you want to commercialise, you've really got to listen to the team around you, because from having the idea to launch, there'll be a point in that journey where you don't have the skills or assets to take it all the way, and you need to literally be receptive to that change and listen to people. Otherwise, you will kind of you will hijack your own kind of project. So the best way to describe that is almost like having a self-driving car like a Tesla. You go down the motorway at 70 miles an hour. You take your hands off the steering wheel. You take your hands off and it's going to be okay. But it's that anxiety of actually taking your hands off the steering wheel and knowing that this car or your project is going to carry on and carry on being fruitful and carry on with this journey. So it's kind of like that. So, if you've got people that are not receptive to change, that is a surefire way of your project failing. IP, I'm not going to talk at length about IP because we all know that this is a very, very kind of tricky subject, but there's usually nothing new under the sun, and it's really important to carry out that due diligence. So even if you were to do a freedom to operate, it's trying to understand where your value proposition is and where there's clear blue water. We've seen lots of ideas where clients haven't really done that really deep dive in terms of where the IP resides, because the whole idea of R&D and research is that your idea is on your balance sheet. That's where your value proposition is. That's where you're going to make money. I think there's an IP firm in the audience at the moment, actually. Shout out. I think one of the speakers is going to touch on this, so I'm just going to give a bit of a broad brush. So human-centered design, participatory design, is something which has become really acute now, particularly with funding. It's always been around. This is all about understanding your target user and approaching your target user from the very outset. So even if you have a concept, you can talk to your potential market and obtain data. It goes back to the conscious bias that when people are the inventor or the innovator, they think that you will create it and they will come. But the reality is you've got to do the hard yards by talking to the intended user, getting to the coalface, having conversations, because innovation really all starts with a conversation. Now I'm trying to look for some miles in the audience. Who knows what this is? A few people. Okay, so this is an example of a kind of a failure of human-centered design. This guy on the left is Sir Clive Sinclair, that made his money in computing in the 80s with ZX81s, if you're a computer buff, which I'm not. And he had this idea, he had this kind of bias that because he'd made his money in computing, that he would translate that knowledge into one-person transportation vehicles. So this is called the Sinclair C5. So you could argue that this is actually, in its own right, in a silo, this is truly innovative because it's the first VeloCycle. It's got a battery, so it's hybrid, so you use pedal power, which charges the battery. So you don't need to use the pedal power all the time. The aerodynamics were designed by Lotus. It's got some complex materials in there as well. So it's quite futuristic, it's quite advanced and innovation in its own right. But the reality is that Sir Clive Sinclair didn't think about the intended user early enough. So when it was launched, after spending lots and lots of money, it completely failed because people didn't want to be sat that low with their knees above a steering wheel trying to go down Newcastle with an articulated lorry bombing past you at 35 miles an hour. So this isn't a good example where it's a great innovation, but you align it with the user and it's a complete failure. Now, if you come to our design studio in Thirsk, you will see a Sinclair C5 in the meeting room on the wall. And that's when people come into the studio and say, I've got this great idea. And we say, have you spoken to your target user? Have you really gone deep? Have you carried out stakeholder engagements? The answer is usually no. Obvious one in terms of reason why good ideas fail is budgets. The key here is, as I said at one of the earlier slides, if you get the right team around you, designers, innovators, IP firms, business people, they can give you a good idea of the realistic budget in terms of what it could cost, but also contingency planning. So we've all seen ideas that have failed because they've run out of money. It's the same with all of us. If you're going to build an extension on your house, you have an idea it's going to cost so much, but it always goes over budget. The key here is to try and get the right people around you that can give that information, because you can't do this, particularly with NEHR or Innovate UK or a VC or anybody really. Next one is technology obsolescence, 7 of 10. So I was born in 1970. So when this was launched, it was a fantastic game. I don't think we're as excited as that, but this is kind of Space Invaders. So this kind of gives an example, and it wasn't that long ago really, it was kind of 1980s, of how technology has accelerated and continues to accelerate. On the left-hand side, we've got one of those phones in the studio just as a kind of to show people when they come into the studio how things have changed. The point of this is that with innovation, R&D and technology, they are accelerating at such a level that when you are innovating, you need to think about an MVP, but also you need to think about how that technology will accelerate within your innovation and how you will keep up with it. So we do lots of work with the wearables, and we have done for 10 years, where the sensor in the wearable is updating every 6 months. Whereas a few years ago, there were 3 or 4 functionalities within a chip that was such a size. All of that functionality is on a chip, which is the size of a rice that you can barely see. So that has a huge impact in terms of what your innovation is and how you continue to be relevant. Commercial awareness, like him or loathe him, it's up to you. James Dyson is a designer, but he's made an extraordinary amount of money using his technology. So part of this is being aware of the market, being commercially aware, where you sit in the market, where your competitors are, where they're going to move, where you're going to move. And it's understanding and keeping relevant and keeping up to date. So obviously, James Dyson launched the vacuum cleaner, is launched into lots of different markets. He even had a crack at EVs a few years ago, which he should have carried on doing, because he probably would be a success now. But this is the whole point, just because you've innovated something, it doesn't mean it's going to be successful. So it's having somebody on your team that's commercially aware as well. Going a bit technical now, TRLs. So technology readiness levels is something you need to be aware of, particularly with funding. You need to understand where you are on the journey. So TRLs were devised by NASA, and it's all about a metric which demonstrates where your project is. 1 being a basic principle and 9 is ready for launch. Sometimes you'll see a TRL which is 0 to 10. The whole point of this is having a systemized process where you understand where you are, so that you are not hoodwinking yourself in terms of being more developed than what you are. So it's a very structured process where you can think about what you need to do, and you can structure your milestones around it. But you see a lot of TRLs. You could talk about TRLs in Innovate UK assessing, for example. And indeed, some funds, for example, Design Foundations for Innovate UK will go up to TRL 3, whereas others are more mature. The final one is to de-risk, risk or de-risk. So the best way I can describe this is an iceberg. So that's an iceberg, but we don't know what kind of size or scale it is because we're kind of at a distance. But as we approach it, we understand what the size of the iceberg is, but actually underneath the iceberg, there's a lot more iceberg. And the whole point of this is, in terms of risk, there are known risks, assumed risks, and unknown risks. And it's the unknown risks that innovators and design-led innovators that you need to try and establish. So we all know risk registers. You know, before we start a project, we'll do a risk register to understand where the risks are, technical, commercial, IP, user. I think the point here is that there are always unknown unknowns, and if you're going to go for funding, you need to demonstrate that you have an idea what those unknowns are and how you're going to mitigate and carry out contingency. So in summary, fail fast, fail cheap, choose the right people, be receptive to change, intellectual property, adopt human-centered design, think about budget control, technology obsolescence, commercial awareness, understanding your TRL and de-risk, or kill your idea, find great people, don't be a jerk, understand the rules, design for other people, look after the pennies, think ahead, choose a good business model, know where you are at all times, and be prepared for curveballs. That's me. Thank you very much.
Thanks, Richard. That was really good. Really enjoyed that. Very good. May the force be with you. Right, just going to hand over to Lindsay, who's going to do her... No, I'm not. I'm going to hand over to Megan, who's online, and she's going to dial in from Alder Hey Innovation Centre.
Hi everyone. Sorry, do I share slides or will they be put up?
Yeah, no, if you share them.
Megan's going to share her screen.
Go ahead.
Sorry, Megan, if you share them from your end.
Sorry, Misha, that what you just said.
Thanks, Megan.
Here we go. Can we see them okay? Well, thank you. Thanks everyone. So hi everyone, I am Megan. I'm a product design engineer by background, and I'm here today to tell you some stories about the importance of creativity in healthcare, how we do it in Alder Hey Children's Hospital, and how you might also be able to reap the rewards of using creativity in your day-to-day lives. Because at the end of the day, I think that we are all creative and that creativity can save lives. But when you hear the word creativity, we usually think of the same things. I hear people say artistic or drawing or music or dance, and who is creative? Most people say artists or designers. So people tell me all the time, I'm just not creative. I can't even draw a stick man. So there we go. Case closed. Some of us just aren't born creative, but I think that's wrong. So who is creative? I'm going to say, especially from working in the Children's Hospital, it is children. We have a youth forum here in Alder Hey, and they are a funny bunch. Imagine walking into a room and there's 30 children all nattering, they're stealing felt tip pens and they're drawing on the walls, and they're the real patients in Alder Hey. So I go in, I'm scared of these rowdy children, and I say, hi, I've made this new thing, what do you think? And they will tell you the truth. And there's this little girl, she's about yay high, and she asks me, how does this product work if my nan falls down the stairs and breaks her leg and the phone is upstairs? Can I send a photo of my dog What if my friend sends a swear word to my doctor? And for context, the product was just letting them send photos of their stitches to their doctor from home. But what do all of these children have in common? They all ask, what if, why, and how? And then they also break rules and they don't have a sense of failure yet. So, what if I told you that's exactly what creativity is, and that's exactly what innovation is? So, how can adults be creative? We can use design thinking, which Richard touched on earlier. So, where did design thinking come from? It started off as a science, really. In the 1960s, designers began applying scientific methodologies to understand how design functions could be improved. Nigel Cross, he did some work and emphasised on the tension between making design a scientific discipline versus a purely creative practice. So during this time, participation design emerged, and this focused on collaboration, but it was mainly used in urban planning. And then Nobel Prize winner Herbert Simon got involved. He introduced the concept of design as a way of thinking in his book, The Sciences of the Artificial. This was very much a turning point in design thinking, and it introduced core principles like rapid prototyping and user observation. And by the end of the decade, participation methods had expanded with usability testing, role playing, and prototyping becoming standard practices across many disciplines, including the likes of architecture as well as technology. So then in 1982, Designerly Ways of Knowing was published, which argued that designers' problem-solving methods differed fundamentally from non-design approaches. Brian Lawson's work also explored how scientists and architects approach complex problems differently, further emphasizing that there's a unique cognitive process involved in doing design. And then Don Norman, I'm sure a lot of people have heard of him, changed that participation design into user-centered design, where we focused on needs, not just usability. And then design thinking was brought into the mainstream. In the 1990s, the very famous IDEO added in the idea of human-centered design. They developed customer-friendly terminologies and toolkits that made the process accessible beyond design professionals. And Richard Buchanan in Carnegie Mellon also discussed how design thinking evolved from the sciences, integrating specialized knowledge from different fields to address global challenges in a holistic way. And then finally, in the 2000s, David Kelly, the co-founder of IDEO, established Stanford's D School, advancing design thinking through education and practice. The methodology rapidly spread across universities and industries, transforming how businesses innovate. So today, design thinking influences not only products, but also services, systems, and social change. It's become essential in addressing complex human-centered problems across sectors such as technology, healthcare, which is what we're discussing today, and education, where creativity and empathy are able to drive solutions. What am I talking about? Tim Brown, the CEO of IDEO, defines design thinking as a human-centered approach that integrates the needs of people, the possibilities of technology, and also the requirements for business success, leading to solutions that will be accepted by end users. And then when we combine that with the fact that innovation is novel solutions that bring benefits, it means that we don't just invent or optimize or break the market, we are able to innovate. So how do we do design thinking? Before creativity can save lives, there's something else that comes first, and it is observation. So we have Florence Nightingale here on the screen, and back in the 1850s, she is watching soldiers die over and over again, but it's not from bullets, it's from infection. And she's able to spot that pattern because she is on the ground. And in 2013, a similar study took place, and it shows that clinical staff do around 27 workarounds every single shift. So what if we were able to use those observations to drive different results? So before creativity saves lives, the empathy comes in, because Einstein said that insanity is to keep doing the same thing every day and expecting different results. and I have a really nice use case for you. I've been working on a project called Isla Care, and it involves improving upon the original offering of sharing photos, videos and forms remotely. So I have workshops with our clinicians to understand what happens at every stage they do, what are their pains and what are their gains, and I get told things, I see things, and I experience three things. The first wiggly child is sat in the clinic on their parent's knee because their GP sent a referral letter ages ago saying that this child has a squint in their eye. The mum's taken time off from work, she's organised childcare, and she's bundled her child into the hospital, and they hear, "You're okay." And obviously that's great, everybody is happy and healthy, but our clinician says that if I had a photo of this earlier on, I could have told her, you're okay, when I first saw that letter ages ago. And then the second wiggly child is in a brightly coloured speech and language therapy room. The therapist is explaining to dad that he needs to do XYZ exercises at home 3 times a week, and here's a leaflet to help. But in Liverpool, the average reading age of an adult is only 7 years old. So dad says, "I'm not confident enough to teach them myself. Can I have another appointment, please? You're much better than this at me." And then the third child has a rash on their skin, and the parents are bringing them in and out of clinics to be reviewed, and we've all been there. As soon as you get to the doctor, everything is magically better again. So they are constantly hearing it's getting better, it's getting worse, oh, it's looking better again, all normal things, but everybody actually forgets if something is getting better or worse because they only have the word rash written down on a piece of paper. So I'm sure we've all been in the similar situation, on the verge of insanity of doing the same thing over and over again. So once we have observed and we've empathised, we are then able to define. We synthesise insights from our research to articulate what is the problem challenge that we are going to work on. And then we're able to ideate. We are able to brainstorm a range of solutions, because I think we know that it's easier to find a great idea when you almost have an Argos catalogue of all the possibilities and you can circle what you want, like what you used to do when you were a little kid for Christmas. And then now that we understand the problems deeply, we've listened, we've acted out scenarios, we've put ourselves through it, showing people that we actually understand and empathise with them is what keeps them on board throughout this process. So going back to the youth forum and the children in general, they ask what if, how and why. And there's a famous prompt in the product design world to get people thinking, and it is, how do you make toast? I'm sure a few people might have seen this exercise before, but in the complex world of healthcare, it can help everybody map workflows, systems, and user journeys. And 9 times out of 10, everybody has a unique approach to making toast. I've seen toasters, I've seen pans, I've seen grills, I've seen open electrical fires, and I'd call that creativity. So to make great solutions, we need to ask ourselves, what if I don't have electricity? What if I don't have an oven mitt and a plate? What if I don't have bread in the first place? And that's how you can create these really wild things. And then once we have the wild idea, the next phase is that experimentation or prototyping. We can make tangible ideas, so starting from low fidelity and getting better. So I could start with spreadsheets or PowerPoints to mock up some software, or sticky tape and cardboard for a surgical tool, before considering the likes of 3D printing or better modelling. And then we are able to test. So then we can refine solutions based on that user feedback, that real use, and those observations. And that's what we do at Alder Hey Innovation. And here's an overview of the process here. This is called the Double Diamond from the Design Council. And we don't just engage clinicians, we engage those diverse perspectives. So if you look at the extremes of people, you're more likely to find the middle ground. And I remember getting told a really funny story where somebody was designing shoes. So they got in a pedicurist and they got somebody in who doesn't wear shoes. So then we can find a nice spot in the middle. And we get problems and solutions submitted from all walks of life. And then as we move into the diamond, as the diamond grows, the information we find grows. So starting with scoping and empathizing, and then as the diamond shrinks, we're honing in closer to the answer. So this will be defining a challenge statement, growing again by ideating and prototyping, and then we get the final answer by testing. And whilst this is a nice diagram, it is more of a mindset, like what Richard mentioned earlier in the first talk. what isn't pictured is that it really does just look like spaghetti. This is an iterative process until we get to an innovative solution that gives benefits for all. So we know that we need the likes of clinicians on board, but we do experience challenges in doing so. A lot of clinicians have jokingly called this creative process witchcraft because it's so far from what they're used to. And those challenges include time constraints. Their ultimate priority is acting as a clinician. How can we get them to talk, and how do they tell us, a non-clinical person, what they mean? And we all know that the NHS does love an acronym. And then also, how do we get them to take on new things, which leads to an additional project and also an additional mental load? So we can do this by encouraging them. Firstly, we create a culture that encourages innovations to be brought forward. We have a dedicated physical space within Alder Hey Children's Hospital, and that physical space almost gives us permission to experiment, because here, once you step through these doors, we can act out, we can get things wrong, and we can play. And this space within the hospital also helps with time constraints, clinical priorities, and communication barriers, because it makes it convenient for clinicians just to come in and visit, engage, and contribute regularly. It is a hub for ideas and discussions, and it also means that we can go to them. So on the right hand side, we went into a theatre so that we could observe a surgery to improve a surgical tool, and that is me on the far right. And I promised that I was pinker before I went in, and I'm very, very yellow in gender, so I think I will cross that out for my career goals to be a surgeon. So how do we find them in the first place? We have a lovely story where the journey begins with something that we call the I Factor competition. And it's not too different from our usual process, but it's an initiative that allows staff to bring their innovative ideas to the table. And you can imagine the buzz that competitions like these bring to the hospital, and that identifies many potential clinical founders. So clinicians submit, they attend boot camps where we teach them about the innovation process, how to spot problems that they experience, and how can we support them in solving them. They then gain almost that ability to fish, this self-supportive knowledge on how to improve their services. And then they also gain public recognition. This is really a very good incentive in the NHS, because it gets people to engage, as they can also then show the fruits of their labour on top of their normal day-to-day work. And then we also find our diverse people. So we do that by communicating in diverse ways. We hold open days, post leaflets, set up computer backgrounds, we knock on doors, because certain people will be able to see certain communications. And this journey was able to lead us to our clinical founder, Dr. E. Smith, on the right-hand side there, who embodies that spirit of innovation. So now we are working on a project called Treat to Target, and this will help children with long-term conditions such as lupus alter treatment until their disease activity is reduced. So we need to engage the clinicians to observe and empathise with them, so then we can reap the rewards, because their input impacts outcomes, safety, and satisfaction. They provide unique user insights because they never act as we predicted them to. We recently observed surgeons interacting with that new surgical tool that I mentioned, and the first thing they did was turn it upside down. And then collaboration with our clinicians and patients ensures that solutions meet practical needs, so that the end goal and that end product is accepted and adopted. And it's had really, really great impact. So for that remote monitoring project that I mentioned earlier, a mum has said, my child is suspected to have ASD and can now avoid stressful appointments and examinations. I can submit evidence and avoid this for my child. In ophthalmology, this was only around a short amount of time. 30% of appointments were shifted to remote, and this saved travelling 4 times around the world, 22 days of clinical time, and over 1,500 hours of patient time saved. And that means all of those wiggly children can be playing in school with their friends. Their parents don't have to worry about taking time off work or doing a disservice to their care. And this process has also impacted our clinicians that have been involved with us. We've observed a noticeable shift from that clinical to innovator mindset, meaning that creativity has increased, communication has improved. We now speak the same language, we now know each other's acronyms. And then they're also now more open to change, and end users are more open to adoption, as that trust has been built throughout the process. So we have seen that asking questions, and so that we can empathise with users, so it does save lives. And then innovation education, like the I Factor competition, also saves lives. And then experimentation and play to create that range of solutions also improves lives. So my recommendations to use the design process in the NHS, as well as keeping people in the heart, is to first bias towards action. Good design is achieved when it's actually made, iterating again and again after thinking. Doing also justifies that clinical time spent innovating as they have those results to show. So we're very much thinking Newton's law. A body at rest tends to stay at rest, and a body in motion tends to stay in motion. Next is to show, don't tell. Communicate what you're thinking by using visuals. It's so much more effective than words. This can be done by creating experiences, using illustrative videos and telling good stories. In the past, we've mocked up rooms to be a whole neonatal intensive care unit, so we can act out how this flow and how this technology will be used. And then it also means that we can then both speak the same language again. And then also embrace experimentation, not only to validate our idea, but to think outside the box, to make and learn from it. So we need to defer judgment for as long as possible so that an idea can evolve. Crazy and impractical things, they are also known in the product design world as sacrificial concepts or ugly ducklings, can lead to those valuable solutions. And an example that I remember reading a while ago, I think it was 2011, Air New Zealand created something called Sky Couches on their long haul flights, but it actually meant that they were able to receive an Airline and Innovator of the Year award. So generating imperfect things will get you closer to saving lives. And then also, as toddlers, we were all bad at walking, but nobody told us that we should abandon the effort. So I do ask myself all the time, why is being bad at creativity met with such fear, such peril? Because if I asked you to sing solo in public now, I think a few of us probably wouldn't. However, under the right conditions, we will willingly sing. And being creativity is the exact same as how children in our youth forum act. It depends on that absence of fear and failure of judgment. So how do we do that? We ask you to keep your sense of humour. We want to build on the energy of others. We want to minimise hierarchy, maybe give the bosses code names or use silent voting. We also want to value team trust. And then again, defer judgment, at least temporarily. If we can give that ugly duckling that time to mature, it could become that golden goose. So if you take home a message today, it is that we are all creative. Everybody can engage in that creative process, and then ultimately creativity can save lives. So thank you so much for your time. And if you want to follow us on LinkedIn to keep up to date with what we're doing, feel free, and that would be brilliant. Thank you so much.
Some lovely slides.
Thank you.
Just going to introduce you now to Lindsay. We're just getting the slides up to date. Brilliant, thank you. So welcome to Lindsay, and I'll hand over. And then Lindsay will be joining us on the expert panel. And then also just a reminder for anyone online, if you want to book a one-to-one with one of the experts and virtual residents, just drop something in the chat. And anyone in the audience that wants a one-to-one, just catch us at the end. Thank you.
Okay, hello everyone. So my name is Lizzie Dodd, as it says up there. I'm an academic, so I'm going to give you a slightly different angle. But I would like to challenge you in this presentation, based on what you've heard so far. Please look through and see if you can spot any of the design techniques that you've heard about so far. I feel like iteration is definitely in there for sure. So also, if anybody would like to connect with me, this appears multiple times, my QR code for LinkedIn. So where it started, it didn't start where you think it might, given that this is an NIHR talk. I had an idea based on a hobby of mine, which you'll see in a second. I pitched that idea to Northern Accelerator, and yeah, let's find out more about that. So, might not be what you expect. I'm a scuba diver. I love scuba diving. But obviously I have a technological background. I'm an electronic engineer by trade, and I was stunned. Scuba divers in general, they dive based on a set of dive tables, which were made in the mid-20th century by a bunch of Navy SEALs, and they're not monitored at all. The basic gist of those tables in the initial sense was come back up from depth slower than your bubbles, and there's a chance you might not die. And those were based on males as well. There was no female representation with those statistics. And ironically, the person that created those tables died as a result of a dive where he suffered from decompression sickness. So, you know, my inner nerd kicked in. I must be able to do something here to make this better. So I had an idea, well, what if we started actually monitoring the humans while they're under the water, rather than assuming that statistically the chances are they might not die, because that's a bit rubbish. So what can we do? Well, in terms of what I do as research as part of my work at Northumbria University is to create wearable sensors, primarily embroidered sensors. So can we start doing some textile-based sensors that a diver could wear? We check some key parameters and hopefully can figure out in real time, do they need to stay down a bit longer? Because when you dive, you come up gradually to let your nitrogen that's super saturated in your body start to dissipate. Can we keep track of them? Tell them to slow down, tell them to wait at 5 meters for a bit longer so they survive the experience. Overall, you know, can we make the divers dive safer and for longer? And my first impression of that, my first idea was to come up with temperature, which isn't a direct indicator of decompression sickness, but I figured let's start with a sensor that is relatable, and then we'll worry about the other stuff later, because the other stuff's a bit harder to measure. So I went through all of the process, you know, let's find a market segment, let's have some lovely educational photographs to explain to people what on earth a diver does, because unless you dive, you might not know. Have my lovely volunteer research assistant there, looking very excited about a dive. She's over there if anybody wants to know. But yeah, there is a big market for this. So I found my problem. I found a potential solution. You know, we're going to all be rich. This is great. We've talked as well, previous conversations have talked about having the right team. So I've got my good idea. I've found a good market segment. Okay, let's get this team together. You've already met the underwater assistant there. But yeah, let's get the right people together. We've got 30 years of experience with the two PADI professionals on the right. Myself, a budding diver with a passion for sensors. My colleague, Professor Hamdi Turan, who is amazing in all things bio. And then, like I say, my two RAs, Beth and Emmy, who are there to be my hands in the lab when teaching is busy, right? So we had the great team, we had the great idea, we had the market share. The problem was making the sensor work. You know, we had this pull, how would we try and sense it? Embroidery with conductive wires can be fun sometimes. And the one that I found that I would like to try, or would have liked to try and emulate, was what's called an RTD. So you have a length of wire, and this wire's resistance varies with temperature. You measure a change of resistance. Great, you can measure a change of temperature. Problem is that's not very small, not very accurate, quite slow, quite big, generally just a bit rubbish, really. It also has a habit of drifting, so all the things you don't want in a sensor, especially when you have this, you know, world-beating idea, the sensor didn't match up. So back to the drawing board, how do we make it faster, smaller, more reliable? And the answer was, well, a Friday afternoon. I don't know how many of you have Friday afternoon moments, but I have Friday afternoon moments about 3 times a week. What can I do to try and find a sensor that does something? And in our lab, we use a lot of things called thermocouples. They're just twisted wire, and you can see one here. I butchered one, took it apart, and thought, well, if I can embroider an RTD, that lovely spiral that you saw that doesn't really work, what if I embroider an actual temperature sensor that already exists and does what I want it to do, but can I just jam it through a bit of neoprene? And that was my whizzo idea. The sensor itself, the actual sensing element is just a little bit of metal in the middle. I don't know why I decided to try and make a spiral. I guess it was just following the iteration of the previous sensor. But this particular technology, it's fast, it's small, it's a proven technology. So yay, we've now got the sensor to go with it as well, right? I'm starting to see pound signs, it's great. And then in the middle of all this, just as I'm getting really excited about saving scuba divers from being hypothermic, we had an approach from the NHS, and I'm like, oh, okay, cool. It was from a neonatal consultant at the South Tyneside and Sunderland Trust. Can we make something for babies? And I'm like, okay, didn't see that coming. Bit of a swerve from a scuba diver trying to avoid sharks and stay warm. So this is where we've now developed to, which is a bit more relevant to why I'm here. So you can see on the picture there, also, if I can hang that over there, if it'll stay put. It might stay put. If it doesn't, I'll pick it up. Can we put temperature sensors in the armpits of babies? Because at the moment, midwives, nurses have to go and manually check the temperature of babies. It can be inconvenient for the baby, for the families, kind of disruptive. So what happens if we had something that is monitoring them continuously? It doesn't impede on their current existence. They're just, you know, in their crib. It could be on a baby grow, like you can see here, but we also had a discussion with the NHS that borderline well babies might not wear something like a baby grow, so it could also go on a hat as well. They had different requirements. We were talking about that iteration of finding the requirements, talking to people. Well, the requirements for a baby and for a scuba diver are very different. Babies having a very narrow temperature range of acceptability. And you can see there the horrible stat of a 30% mortality rate for every degree below that safe range, which is quite daunting, actually, quite terrifying. So can we automate this? If we've got the temperature sensor, the automation, I would argue, is just a little bit of engineering, bit of coding. And can we look at the trends? Because if you've got a midwife or a nurse monitoring the temperature every few hours, they don't know if that infant is cold. Are they on a downward trend? Are they coming back up from even colder? So the trends themselves we were were very, very useful. So off we went into our nice scribbly diagram of uncertainty and tried to iterate, tried to design something that would be beneficial. We start off on the top with some big electronics and a baby grow similar to this one, proving that we can just have a prototype there. We have a temperature that's being measured in a garment remotely to a phone over the internet. We've made the electronics smaller, still not small enough, right? We wouldn't want to strap that to the side of a baby, but it shows that the reduction size is there. So we've got a functional prototype. The eventual aim, as you can see from the other diagrams, is some mock-ups from a design collaborator who helped us. The idea is we would go custom, flexible PCB, and then we can go further with that and make it more useful. The right-hand side there shows you our spec as determined by the NHS. So we had to have 1 degree of accuracy. We had to have an alarm. We had to have a colour alert. Don't disturb the baby. Very important. Don't disturb the baby or the parents for that matter. It had to be cuddle-proof, which, you know, for an engineer is not the best thing to say. I define cuddle-proof. Foolproof, cost-effective, and low-tech, again, not the nicest words for me to hear. And the one that I think is the hardest in all that is integration into the electronic record system as it stands for whichever trust would want it. So quite a demanding set of requirements there. And like I say, what is cuddle-proof? Yeah, I'm still learning. So we had a prototype for a scuba diver, which I'd worn. We had a prototype for an infant, which no infant has worn, ethics. The hard bit I've found so far, at least, is the funds. So we've had limited funds so far. Northern Accelerator and internal Northumbria University funding have been very good to us, and we've achieved quite a lot with quite a little. But I think it's important to acknowledge that the first 80-90% can get there on a certain amount, but the last 10% is disproportionately expensive in terms of making those last steps. We've been unsuccessful with both the MRC and the NIHR. So I'm actually on an iCure course right now, so I guess this is a bit of a pitch. If anybody would like to talk to me about either this market segment or any other market segments that you think this device would be useful for, please do talk to me. We're kind of thinking, well, okay, if the NHS is difficult to break into, can we get that iteration through other market segments and then kind of swing back around near the end once we have a more refined solution? But given that we've already seen with the scuba diving and the babies, the requirements for each market are very different. It may or may not translate that way. So yeah, the market segments we've looked at so far. Like I say, I'm on an IKEA Discover course at the moment. So we, had a bit of a sit down and a think. We're thinking critical medical, which we've obviously covered. Some human care, so maybe not in a hospital, maybe at home, or maybe for a sports application. Femtech, relating to cycles, IVF, menopause, things like that relating to temperature. Maybe some veterinary care, so if we can't strap it to a baby, can we strap it to a dog or a horse, or maybe even a camel, I think we discussed at one point. And also food, drink and pharma, expensive beverages, expensive foods, expensive drugs. So, key takeaways. I finally managed to get a picture of myself in the slideshow. I had a few key takeaways. Main one for me was trying to protect the idea, because it was very difficult to talk to anybody about anything in any detail if I'm not allowed to tell them what I've done. So we have filed a patent, which means I can actually stand up here and tell you about it. Effective pitching. If you're not very good at talking to people, it doesn't matter how good your idea is, you're not going to get very far. I hope I'm doing okay, by the way. Collaborate. So we've heard from others as well. You've got to be willing to talk to people. You've got to be willing to iterate that idea and be open about what you're doing. Funding. Yeah, difficult. Persevere, again, you've heard from more than just me about that. Perseverance and finding that desire to keep going with it is always very, very important. And you can see just a quick thing with that picture. What I show you here is very different to what you see there. So this is me in a pool. This pool is very, very warm, and that is a neoprene dry suit. I'm absolutely dying in there. But that particular iteration, I don't know if you can see, there's a wire coming from my wrist, and then it's going in the water and going down to a Ziploc bag full of electronics on the side of the pool. I have an RA who's also in the room, stood on the side getting ready to drag me out, and a safety diver who was in the room keeping me safe as well. So it just goes to show you the iteration might not be the same linear path you thought, going from me trying not to overheat in a dry suit to a baby growing a talk for the NIHR. So never underestimate the importance of a WISO idea, but also bear in mind it might not end up being useful in the way that you thought it was. And with that, I'd like to thank you all for your attention. Please do add me on LinkedIn, and please come and talk to me if you have any insight on any of the market segments I've mentioned. Thank you very much. Okay.
Thank you, Lindsay. That was brilliant. We're now going to move into the expert panel. So the keynotes will be on the panel. Megan will be on the panel, but she'll be online. And we'll also be joined by Ben and Matthew. So if I can invite you all to the stage, that would be lovely. Thank you. If anyone's got any questions online, if they could put them in the chat, and then we'll pick them up from the chat and put them to the experts. And I'll just pause a second as well for Matthew and Ben to introduce themselves as well. I'll just wait for him to come on stage. Oh, no, it's fine. If you just sit down, we've got a roving mic.
Is that mic on, Stu?
Hello?
There
Oh,
it
okay.
is.
Hello.
Apologies for the cold. I've got a bit of a sniffle. So my name is Ben Porter. I'm the Programme Manager at Health Innovation North East North Cumbria. So we're one of 15 networks across England who essentially support a lot of SMEs, academics, clinicians, sole traders, big pharma, essentially with developing their ideas for the NHS and social care. So we really have a broad remit, similar to like the NIHR, for example, where we can help people understand whether or not that idea is suitable for the NHS. We can help them navigate some of the complexities around understanding regulation, understand how to generate evidence, and kind of broker those links to the relevant partners who can help support their innovation kind of come to fruition with ultimately adoption in the NHS. I'll hand over to Matthew.
Thanks, Ben.
Thank you. Matthew Leavesley from Northumbria University Design School. Just briefly on the university, we've got a new research group that is bridging between our healthcare school and the design school, both of which are very strong schools within Northumbria. So we're expecting that to generate lots of kind of interesting opportunities, ideas coming out of that in the future. From my own side, I've got a background a little bit like Richard's, actually, starting in business as a product designer and then moving into academia to teach onto those sorts of programs, teaching innovation at master's level as well. And currently, I do more of my innovation work with NHS partners. And I suppose, so that just so that you know something about me, I've most recently been working within a neonatal unit within the Royal Victoria Infirmary. And we've got pretty good changes happening within that unit over the last 3 or 4 years. So that is applying design thinking in more of a service innovation, service development way. But again, it uses all of those same tools that you've heard about today. So very much a co-design approach involving other people within the service. People much more expert on healthcare than I am, but working in a facilitated way so that we all think more adventurously. Okay, thank you.
Thanks, Matthew. Has anyone in the audience got any questions for any of the keynotes from their presentations or the experts that have joined the panel? And, of course, Megan online as well. Has anyone in the audience got a question? Brilliant, thank you. Hi.
I'll just bring the mic up.
Hi. Question for Lindsay. I was trying to follow the journey. You started with a great idea, which is still a great idea. You had a suggestion from a clinician in South Tyneside, and you pivoted to there.
Yep.
I guess at some point, you say you're at the stage now where you want to continue the funding, etc.
Mm-hmm.
I'm trying to connect it to the first talk, but my question is, and sorry if it's not to be rude or anything, but can you just not dismiss that and go back to your original idea? It seems from an audience perspective like you went off on a pivot.
Mm-hmm.
But is it not an option just to go back to your original and carry on without wondering about the other possibilities?
Yes,
And maybe make you more focused?
Certainly. So a lot of it has been funding driven, so just having enough people time and people power to keep both going simultaneously. So what I've been doing, albeit with 2 sort of hats on, scuba diving and neonate, is to trying to develop the technology into something that's very robust, very repeatable. I have another thing with me somewhere, I'll find it, with all the different varieties of sensor that we have for what I've been calling the temperature sensor, applicable to both applications. And then, like I said, this IQ course came up, so it was a case of, okay, how can I go even further, right? The horizon scanning is getting wider rather than narrower, so a lot of parallel work going on while just improving the tech as a fundamental concept simultaneously. So yeah, I haven't ruled out scuba diving. If anything, I'm trying to find even more to then narrow back in again, if that answers your question. Thanks.
Have we got any questions online? Sorry. Sorry, Sherilyn.
Hello, right, so we've got a couple of questions from Ian Newington. One for Richard. He said, great talk as usual. If there was one thing the funders could do to facilitate your 10 things, what would it be?
Thanks, Ian.
Sounds like a dissertation.
With one of those 10 things, did you say, sorry?
Yes, if there was one thing the funders could do to facilitate your 10 things.
I think, particularly with startups, obviously funding is really critical. So there are things that you can do that don't cost money. So, for example, if you have a team around you that believe in it, you know, a non-exec chairman or something, or a mentor, then that's the way I would start it. So I would think holistically about the things that you can access that don't cost money. Obviously, NEHR have got some good resources, RSS, for example, that can help you, will give you a critical analysis of a funding that you might want to go with. So I would approach this in terms of team. I'm a firm believer in mentors. You know, I'm a mentor. I firmly believe that that's the way you would do it, is don't get focused on the technology. I think the whole point of my presentation was I didn't actually talk about the idea. I spoke about the things that hang off of the idea. So you need to approach them in equal measure. But I'd say, you know, get the right team, because they can really help accelerate the journey, tell you when to stop, tell you when to do things, how to be connected with other people and networks. So I'd say really look at the things that you can do that don't cost money.
That's Richard.
Great, thank you. We've got another question, which I think is to anyone in the panel. So is there any advice to forming your team if colleagues aren't as passionate about the area as you are?
Matthew looks like he's going to say something.
I don't have a good answer to that, but I do know that if you can build a diverse team, and that does mean that sometimes people aren't agreeing with you, that generally has better innovation outcomes in terms of when this is measured in big business. So actually having a few skeptics is actually really healthy. In our project with sort of neonatal care, we definitely had some skeptics in the team. We had obviously a big cross section of medics and nurses and parents, and we didn't meet skepticism from parents because they knew changes were needed, but we did meet skepticism from some of the clinicians, some of the team. I suppose the way to handle it is to expect the skeptics, try to keep them on board, and see if they can be turned into advocates by the end. And we did manage that actually in this project. So if you can do that, they actually become what, I don't have a word for it, but I'm tempted to call them super advocates. They are potentially the super advocates that you can get to at the end of the project. Who are the most vocal because they didn't believe in it, but you kind of, you know, take them through what I think all of us in the presentations have described as a process of discovery, and by the end, I think you can tilt people towards you. So
I think that's really good, actually. Really good positive solution.
I'm just going to add to that as well. From my personal experience over the past 2 or 3 years now supporting SMEs, one of the key struggles I see them finding is that when they don't have a clinical champion, it's really hard to kind of push that innovation further forward. You know, the clinical champions can quite often open some doors, and in particular when it comes to applying for the likes of I4I funding or various other funding pots with Innovate UK, you need to have those clinical partners, and having those early on or identifying those early on can be very, very helpful, I find. So whilst that might not be a team per se, having a clinical champion definitely supports your innovation journey moving forwards, I think, if you can get those early on.
Thanks, Ben. How would you find a clinical champion? How would you go about it?
Well, it depends. So sometimes it can be helpful linking up with NIHR, so with some of their expert partnering service. You know, that can be really, really sensible and helpful for that. Other times, working with the health innovation networks, they're very, very closely connected with some of the NHS trusts, so with the ICB. So they can also help broker some of those introductions as well. So they'd be the first 2 ports of call I'd suggest. Yeah.
Thanks, Ben. Richard was going to add something as well, I think.
Yeah, am I?
Yeah, you're
Yeah,
right.
so I think with my leadership head on, there's something called psychological safety. So it's really about getting the right balance of people around that team. So you don't want, for me, it's really about understanding the mission statement, so where you are going to get to, what the mission is, what the strategy is, what the end goal is, and I think it's how you will get there. So I think it's okay to have people that challenge, but in this psychological safety, and the way I would approach this is to, you know, you do need to have disparate people. That's the, you know, hence the Star Wars thing, and sometimes you do fall out. But actually, if you've all got this aligned mission, then it's actually okay. So it's kind of a balancing act, really. I think that you need people that are invested, that understand this is going to be a long journey, and there will be lots and lots of bumps in the road, and it's down to the perseverance of a team. So I think part of it, you know, is really about navigating leadership. So it's just getting the right balance. You don't want groups of people that all have the same opinion, groupthink. You don't want people that are kind of infighting. So, but the thing that would align it is the end goal, the mission statement, the objective.
Justin? 2 seconds.
Question for Megan. What we've heard about and learnt about, so thanks everybody, is the product development process. What I'm interested to learn about from you, Megan, is how the products, once they're developed, then get taken into production. So some people talk about search versus execute, or explore versus exploit. How did you, or how do you manage that transition from the development process into production and delivery?
Hi, thank you. Great question. The way I would describe it is, when I had that double diamond up before, one of the key phases is something that we call validate. So what we essentially do, and how I like to do it, is let's brainstorm everywhere where this project can go wrong, and then let's order them. So again, it can go from your riskiest assumption to your least riskiest assumption. And then during that validate process, we aim to answer those questions. And it means that once we hit that filter, we can fail fast. And one of those things might be, what would this look like at business as usual? And how might we grow this? So that's how we will aim to develop a plan around that. So there's no necessary set answer. But one example I can give at the moment is with one of our projects called Little Hearts at Home. So that supports the remote monitoring of children in the community. So we use the community nurses. And what enabled that was, once we mapped out the as-is process, we could map out that to be. What is this going to look like? Let's iron out how this can be operationalised. And then also touching on the point of clinical champions, it means that you're able to get people on board because they can see what their life is going to look like after it has been implemented. And the way that one is working is almost like a mini spin-out. So around that, again, working out what can go wrong. It can be things like your IT security, or how do people raise tickets. So that's one element. Another element that we're exploring at the moment is finding somebody else that's an expert in the area. Maybe they've got technology already in the NHS or up and down the UK. And what we might actually do is license out our products to them. So then they can look after it for us, and then it can be their baby. So they're two models that have gone quite well. So there's that homegrown element, and then that sharing and co-creation elements, if that answers your question.
Thanks, Megan. Thank you.
Thank you.
Thank you. Chelsea Brain, Northumbria University. I think this might be more of a question for Richard and Megan, but it's to do with, in that design process, when you're taking into account kind of what people say, you know, what they think, what they actually do, and they can be two quite different things, which can lead you into different directions in terms of that design process. Like, how do you interrogate that? Like, what techniques do you do to try and understand whether what people are saying is actually quite different and perhaps how they might use something which, you know, could risk you ending up with the kind of wrong design of something? How do you do that? And does that happen often?
Really good question. And me and Megan are experts in this. So this is the designer's eye. So when I use the word interrogation on my presentation, I kind of use it lightly. The key point is to extract data that is non-biased, objective and qualitative. And you are right that people will tell you things that they think you want to know. So starts a project for us is that user insight. So whether it's curating a bunch of heart surgeons or whether it's patient experts, there's a way as designers that we can see things that other people kind of can't see. So there's a process that we go through in terms of how that information is extracted. So number one, it's getting the right quality of people. So in terms of a heart surgeon, newly qualified, or some, a range of 6 to 8 surgeons of different range of experience, and then talking to them about their experiences in clinically, what the barriers are, so them imparting their information. And then it's not showing them some concepts and saying, what do you think about that? There's a way that we would extract the information that means that they are not telling us what they think we want to hear. So there's tips and techniques that we use, and we use the same KOLs to kind of revisit. So there are defined processes, and as designers, that's the real value of the whole thing of designers, and I guess this presentation, that other people can't see. So what we don't want to do is work with clinicians that have got huge egos, because it is really difficult to extract. And what will tend to happen is they will hijack the whole of the meeting. So there are ways that you can kind of divide and conquer to extract information and to validate it, in answer to your question. But that's the key to the whole thing, because if as designers we take the information as read, we can end up building a house in a different city, and we won't know until we've got to that first validation phase that it's completely wrong. So it's all about that insight phase, but the double diamond, the insight, that's what it's all about.
Mm-hmm. Yeah, I completely resonate with what's just being said. What I tend to do at the moment is split out the surgeons, because we do have surgeons with so much experience, and I also don't want to invalidate that. So what we might do is one-on-one observation, because otherwise you might see a natural sheep mentality where people will agree with the biggest voice in the room. But we will then observe their interactions, and what I'd also recommend is having more than one person. So it might be me and 3 other people, and I might say, okay, you take a note of what you see, you take a note of what you hear, you make a note of what is actually done, and then we can compile those at the end. But then I would naturally prioritise what is seen and what is naturally done, because I think these days we can make all these amazing products because there's so much technology out there, but at the end of the day we want it to feel intuitive, and then that will lead to that acceptance at the end of the day. So the more natural a product can feel, the more likely you are to get people on board with that business as usual.
Thank you. I've got maybe one more question for Megan, if that's okay. When you're going through this design process, particularly in relation to NHS, do you engage kind of broader NHS in that, including, for example, NHS procurement? Whether there's certain things that maybe kind of have to be met in order for a product to kind of be procured through that process in the NHS?
Yeah, definitely. So when a problem comes into us, we will have a triage process. And one of the things is just looking on the market, is somebody already doing this? If not, why is this not being done? And then sometimes that might involve a conversation with procurement. And then if there isn't anything out there, we tend to then have conversations with clinical safety, information governance, procurement, to understand what constraints there are that we might have to adhere to. I always say, again, I've seen it quite a few times in the NHS, it's almost like building a bathroom with a socket in it, and then you go, oh wait, we're not allowed that socket, and the whole thing needs to be rebuilt. So understanding those constraints from the start are really helpful. So again, I think at the moment there's a big conversation around multi-factor authentication. So having those at the start will speed up your procurement at the end, because you don't have to go back and rebuild it and go off budget, go off scope, etc. And then also being constrained isn't necessarily a bad thing, because I do think that it means that you can generate even more innovative solutions when you are in between a rock and a hard place.
Anyone else got any questions? Anything online? One more online. Sorry, Sharon. Get your steps in.
Right, this is quite a long one, so I'm just going to... so it's from Sarah. She said, thank you so much for the brilliant session so far. I used to do lots of engagement with clinicians to surface needs and help them explore solutions. I often heard from clinicians, can we fail fast and experiment so that we can focus on the most promising ideas and get tangible results of our innovation projects? So my question at the expert panel would be, one, how do you go about the messy and often not formalised preliminary assessment of the need or idea to prioritise the most impactful ones? I'll give you that question first and I'll go on to the second question.
That was a long question.
That was a long question.
It was.
That was kind of 3 questions in one.
So I guess we're talking about acceptance criteria, really. So there are stage gates. So, you know, you can call it a design sprint or a kind of a sandpit event. But normally, innovation starts with conversations and doing stuff. So in our design studio, we've got like a workshop where we just kind of play around with things just to see what might work and what might not work. And I think the whole idea is, Megan mentioned earlier, it's this divergent thinking. So don't think about things too much. Just get some ideas down and make things and sprint, you know, and don't be afraid of failure. But I think, you know, in order to do that, you need to have some kind of acceptance criteria. The whole point of the double diamond is you do that divergent thinking piece. It's the first diamond, and then you kind of assess what you've created, and then through that, after that first phase of the double diamond, you kind of reject ideas that are still good ideas, not for now, but maybe for later. I think the short answer to that question is to create an acceptance criteria at the end of the first double diamond.
Okay, thank you. And the second question was, how can you practically arrange the solution exploration phase so that clinicians can see the need idea in a more tangible way and collaborate on the possible design, i.e. rapid iteration, prototyping, sketching, storyboards, demos, etc.?
I'll have a go at that. So, I mean, we're from industry, so we do this all the time. We bought our first 3D printer in 2008 because the challenge you've got when you create something, a concept, for example, a 3-dimensional sketch on a 2-dimensional piece of paper, and you communicate that to a stakeholder, a clinician or a patient, they will be receiving that information which might not be in parity. So if I say green chair, we're all thinking about green chairs, but it's still a green chair. So we went into 3D a long time ago because when you put something in a, for example, a surgeon's hands, then you've got parity in terms of its shape, form factor, and then you can start to accelerate the journey. 10 years ago, we invested in VR because we thought that it's good to create the environment for a surgeon by putting the headset on, and then, yes, it's virtual, but their behaviours change because they are immersed in the environment, and you can observe them differently. So there are relatively inexpensive tips and techniques that you can adopt that can really accelerate that journey. But I'd say all of them, storyboarding, sketch, well, initially storyboard, sketch, 3-dimensional sketch models, iterative models, VR, AR, anything that's at your fingertips that you can use to get that parity with your stakeholders so you're both talking the same language.
Brilliant. Thank you, Richard. I actually don't think we've got time for any more questions because it's 11:29. So just want to say a big thank you to Keynotes, panel, Megan dialing in, everyone attending and attending online and for your questions. It was a really interactive session, and look forward to seeing you in January for the State of the Nation event. Can't remember exactly which date in January, but it was in the slides. Thank you.